right, just a second now, Donna.
Okay.
It looks like you're ready. You're good to go when you're ready.
Okay. Good evening, everyone. My name is Donna Gunkel, and I'm the Director of Clinical Integration here at United Medical ACO. Welcome to our Wednesday Wellness webinar. We hold this now once per month. It is the second Wednesday. And on the fourth Wednesday, we're now doing a diabetes support group, which Amy will talk more about at the end. So this is Wednesday, September the 8th. And I am going to share my screen. All right. Okay, let me just go back. Sorry. There for a second, all I saw was a black screen. Okay, so this is our wellness program team. Kamal Erkin, our chairman and CEO of United Medical ACO, cannot be with us tonight, so I'm going to be your host. We have Dr. Hundle with us tonight. He is our program director. Part of the team also includes Tim McHugh, a physical therapist who talks to us about fitness and exercise. Amy Wilcoxon is also here with us this evening. She is a registered dietitian and a certified diabetes educator. And Jackie Tomasetti is our licensed clinical social worker. So I am going to now turn it over to Amy, who will talk to us about what the program consists of, and then we'll start in with this evening's presentation.
Okay, we still have the title slide up, Donna.
Can you see it? On my side, it shows Wellness Wednesday webinar program.
Still just the title, so the United Medical ACO Diabetes Program. The first slide is what we're seeing.
Oh. So you did not see the team?
No, the team that you introduced, I don't know if Dr. Hundle can see what slide he's seeing.
It's just the first slide is there, that's all.
Oh, okay. Hold on, guys. Can you see it now?
Nope.
All right. Are you able to see it now?
There, okay. All right. There we go. Now we've got it.
So
Okay.
I do apologize. I'll go back 1 second just so this is what I was presenting. So this is our wellness program team. Just so everyone has a moment to see that, I do apologize. And now hopefully we are on track with the slides, maybe. Okay, there you go.
Okay, there we go. All right, thank you, Donna. So this is, as Donna referenced, our Wednesday webinar program that we now do on the second Wednesday of the month. So we've had many specialists coming to talk about different things related to diabetes, whether it be food or heart disease or kidneys, podiatry, mental health aspect, exercise. So we've been doing these since last July or August, I believe, and they are all
in August 2020
on our YouTube channel if you want to go back to them. And then Donna, if you can go to the next slide. Thank you. We have Dr. Hundle tonight, who's the director of our program. Thank you for joining us. And Dr. Hundle, I'll turn it over to you.
All right, thank you very much. All right, so now I will be moving the slides or it will move by itself.
You should be able to, Dr. Hundle, if you just hit the arrows on your keyboard. If not, let me know and I can handle it for you.
It's not moving.
Okay.
I guess I will just have to ask you then. Okay, all right. So is it like why it's cut off at the bottom? Is the screen like it's?
Can you see the screen, Dr. Hundle?
Yeah, I can see it.
Okay.
I thought maybe it's at the bottom, it's a little bit cut off. So Today, we're going to continue our discussion on a different medication used for treatment of type 2 diabetes. So previously, we have touched on the other medication, including the metformin, sulfonylureas. Then I believe we discussed about the medication like the pioglitazone. So to continue on the same regimen, like we will now go to the next classes of drugs. So here on this slide is just a general to go over the defects in people with diabetes, is that their pancreatic cells, they don't make sufficient insulin. They have inappropriate glucagon secretion, which is a counter-regulatory hormone and makes blood sugar go up. Then at the level of the muscles, they are insulin resistant, as well as in the fat cells. They do not take up the glucose in the cells in response to insulin secretion. Then in the level of the kidneys, the kidneys tend to reabsorb a lot of glucose back into the system. In the liver, it's making excessive amount of glucose constantly, which also leads to high blood sugars in the blood. And then in the gut is obviously the incretin effect, that this is the important hormone which regulates the insulin secretion that is defective. And then there's a quick absorption of the glucose into the bloodstream. So next slide. Yes. So these are different classes of medications which work on different targets. There is also the brain also to some extent is not that effective in sending signals to the pancreas to make more insulin. So today we are going to touch on two important drugs. One is these are called the SGLT2 inhibitors. They work on the kidneys. And the other one are the incretins. These are the GLp1 receptor agonist. So we will discuss these two main drugs. So next slide. Next one. So this is a very interesting slide and a study done where people were given glucose either by mouth or through intravenous, through they're putting a IV in and giving glucose through the vein, keeping the blood sugars almost close to each other. So then they looked at the insulin secretion shown on your right-hand side. So the red bar is the one where it was given, red colored is where it was given by mouth, versus blue one color is when they're given intravenous glucose. So this study showed that although the plasma concentration was similar by the two routes, but when glucose was administered by mouth, there is much higher increase in insulin release as compared to intravenous. So it was thought that there may be some gut hormones which are being secreted in response to our food intake, which is causing increased release of the insulin to keep the blood sugars in a better range. Next slide. So then these hormones were discovered. There are two important hormones. One is called the GLp1, glucagon-like peptide 1. This is secreted by the distal, like the part of the small intestine just before. This is the small intestines. Then goes into the large intestines. So this is in the later part of the small intestines, just near the appendix. That's where these L cells are. And these are the cells which secrete this hormone. Then in the part called jejunum, which is after the first part is the stomach, then second part is called the duodenum, and then the third part is called the jejunum. This is all part of the stomach and the later intestines. So the K cells in the jejunum secrete another hormone called the GIP. So these are two important hormones which were discovered, and over the next slides we'll see how they help with insulin secretion. So next slide. So in this slides, these subjects were infused with the GLP1 and the GIP. This is in healthy subjects. So they were infused with these hormones, and they looked at the glucose secretion, glucose levels, and the insulin secretion. So in the left-hand slide, you see that yellow is when they were just given placebo or saline. Then the blue one is the GLP1 and the GIP is the pink one. So when they were infused GIP and GLP1, you see the glucose levels were lower as compared to saline infusion. And this was because of what is shown on the right-hand side. With the GLP1 and GIP, there was much higher release of the insulin as compared to when saline was infused. So again, showing that these hormones play an important role in augmenting insulin secretion. Next slide. So the glucagon like peptide 1, this is the more, the important hormone based on which other drugs have been used for the treatment of type 2 diabetes. So to highlight the main important functions of the GLP-1 is that it stimulates the beta cell function. That is, the beta cells are the cells which secrete insulin. They are in the pancreas. So they help to increase the insulin secretion, helps to synthesize new insulin, some cell growth over there for the beta cells, and it prevents the early death of these cells. Then the second important function is it decreases the glucagon release. So as I explained earlier, glucagon is a counter-regulatory hormone which augments insulin, which augments after glucagon, the glucose levels tends to go higher. This is the hormone which we use when patients suddenly become hypoglycemic. Blood sugar drops low, they become unconscious, they cannot take by mouth, so we inject glucagon to quickly bring their blood sugars up. So when the glucagon level goes down in response to this hormone, blood sugars don't go that high. Then it also slows the gastric emptying. So people feel like they feel full quicker. So they end up eating less. It then also works in the higher centers and helps to inhibit their food intake. Their appetite goes down, so they don't keep on eating. And then through indirect effect on insulin and the glucagon, it helps to shut down the excessive glucose production by the liver. And because of the increased insulin secretion, it helps to move the glucose into the muscles, into the fat cells. So all these effects thereby helps to lower the blood sugars. Next slide. So here there are multiple effects of this hormone made by the gut. So it works on the brain also. As I explained earlier, decreases appetite. There have been some studies showing that there may be some neuroprotection effect in the heart. There have been ongoing studies have shown that it may be protective for the heart, helps to improve the cardiac output, so better blood delivery, right? Pumps better, so the blood goes to the circulation much more effectively. Works on the stomach to slow the gastric emptying, works on the islet cells, as explained earlier, augmenting insulin secretion and decreases the glucagon secretion. And by these two things, doing these two, insulin and glucagon, it helps to decrease the glucose production by the liver and increase the glucose delivery into the muscles. Next slide. So the GLP works in a it's called glucose dependent fashion. So when the blood sugars are high, it will work. When the blood sugars return back to close to normal range, it will stop working. So you need this hormone when the blood sugars are high. So in this slide, the GLP-1 was infused. So here there is the GLP-1 is shown here in orange, and the other one, the blue one, is the saline infusion. So blood sugars running high, when we infuse GLP-1, the blood sugars nicely comes down. Why? Because it helps to augment insulin secretion. So the C-peptide is the equivalent to insulin secretion. So here, as the GLP-1 infusion is going on, there is higher amount of insulin being secreted and blood sugars comes down nicely. The glucagon, as explained earlier, in response to the GLP-1 goes down. Now, as you see that the blood sugars, when they are coming closer to the normal range, the insulin secretion tends to fall down and the glucagon levels starts coming up. So this is a very sophisticated way of controlling the blood sugars. So it will work when the blood sugars are running high, but the moment blood sugars are getting close to normal range, the hormonal secretion will go back to their baseline. So thereby, with this medication, there is very, very low risk of low blood sugar reactions. Next slide. So there are a lot of medications available based on this GLP-1 hormone. So these are medications which binds to the receptors where the GLP-1 is supposed to act and does all the actions which I explained earlier. So there is this exenatide, which I'll name the trade name too. So if you're familiar with that, with the Byetta, that was used to be used. Still is, it's in the market, but we rarely write it now because of the better medication. Then there is this long-acting form of exenatide called the Bydureon. Then liraglutide, that is available as Victoza. Then this dulaglutide, that is the Trulicity. Nowadays, you must have been seeing a lot of ads on the TV also. And the last one is called the Ozempic, which is the semaglutide, that is injectable form. And the semaglutide is also available in form of oral form, that is called Rybelsus. So these are different GLP-1 agonists available on the market. So basically, how they work, they activate the GLP-1 receptor and does what it's supposed to do. The main side effects, because it's the way it works on the stomach, some people can experience some GI side effects with nausea, some vomiting, abdominal pain can happen. It's not that common. It can happen more often if patients are used to eating big meals because it slows the stomach emptying. So the food may sit there for a longer period of time and people may feel nauseous. So you have to educate the patients that it's important to cut back on the portion size. Then there is a very, very rare risk of pancreatitis. So we always should be aware of the side effects that if you develop any consistent nausea, vomiting, swear, abdominal pain, going to the back, immediately stop the medication, call your healthcare providers. If it's too severe, then they obviously have to go to the emergency room. But again, this is a very, very rare complication. Then there is some risk of, this is called medullary thyroid cancer. This was seen in the rat models when this drug was being developed. How it relates to the humans is not really clear, but just because it can increase the calcitonin secreting thyroid cells. So this is called medullary thyroid cancer. It's a very, 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 very rare type of thyroid cancer. So just we have to make sure that if you have this type of thyroid cancer yourself or family members, then tell your providers so you should not be on this medication. Then the way it works on the higher centers in the brain, it helps to suppress appetite. So usually we see weight loss with this medication. And the one more thing with this, because of the long half-life of this medication, it's advisable not to use during pregnancy. It hasn't been studied. And if somebody is planning for pregnancy, usually we need to stop the medication 2 months before the plans are there for getting pregnant because of the longer half-life of the medication. So, and the bottom, I've just listed these medications based on the renal functions. Your provider will know about this, but again, that's how you basically use the medication based on the kidney function test. So that's important. Next slide. And these are the other drugs, the liraglutide that is given daily. Here, there's no renal or hepatic dosing impairment adjustment. Trulicity is given once a week. The Ozempic is given once a week. These are injectable form of therapy. And the only oral medication available at this time is called the Rybelsus, which is given by mouth once daily. It has to be given by special way, fasting, first thing in the morning, half hour before breakfast. Should not be taken with any other medication. So take it with 4 ounces of water. Half hour later, you can do whatever you want. So next slide. These medications, one good thing about the medication is, yes, they have been approved for treatment of type 2 diabetes. But in addition, the studies have shown that they reduce the risk of myocardial infarction, which is heart attacks, stroke, and cardiovascular death in adults with type 2 diabetes who have underlying heart disease. So that's another indication that people with diabetes are at very high risk of heart disease anyhow. So we can use in those individuals, and especially in people who already have experienced heart problems in the past, stroke, we can use these medications in addition to decrease the chance of dying increasing their chance of having another heart attack or stroke down the line. So next slide. So this is the other class of medication. These are called serum like glucose transporters. These are, just go back. Yes. These are sodium glucose co-transporter 2 inhibitors. So in the next slide, normally for a normal individual, very high amount of glucose is like sort of released into the kidneys from the circulation. It's almost like 180 liters per day. But you never see glucose in the urine of a normal healthy individual because kidneys are equipped with these receptors over there, transporters over there, which pulls all this glucose back into the system. So there are the S1 co-transporters, which pulls out 90% of the glucose, and the SGLT1. These are the one which can pull up to 10%. So basically, that's the reason why we never see any glucose in the urine. So when the scientists were developing these drugs, they said, why can't we block these receptors and say, get rid of extra glucose in the urine? So based on this, these inhibitors of the SGLT2 inhibitors, the first one, where there is 90% absorption of the glucose, they made these drugs to work on these co-transporters. Next slide. So these are the other medications which you must be familiar with or are on these medication. So the first one is called the canagliflozin, that is Involcana. Second one, dapagliflozin, that is available as Farsiga. Then Jardiance, that is empagliflozin. And the last one is called the Stiglatro or the ortogliflozin. So this is the SGLT2 inhibitors, 4 of them available on the market. They're given by mouth only. So these are tablets. Helps to reduce the blood sugars by getting rid of extra glucose in the urine. So the main other side effects which can happen is, since it makes leak more glucose in the urine, there's a risk for genital fungal infection, both in males and females. So it's important to have good personal hygiene, keep yourself well hydrated, then you can avoid these infections. These are not that common, but again, if somebody is getting repeated infection, then we have to stop the medication. There's higher risk for urinary tract infections that can happen, or other kidney infections. So just have to keep those things in mind, but these are not, again, very, very common side effects. Blood pressure can be run on the lower side, reason being because it makes, along with glucose, it pulls more fluid, more water in the urine, so need to keep well hydrated. Otherwise, some people can have more drop in the blood pressure. But typically, they drop blood pressure by only 3 to 5 points. Small increase in the LDL, the bad cholesterol. Then there have been case reports of what is called diabetic ketoacidosis. So it's a condition where there can be increased ketone production built up in the body. So anybody with nausea, sudden nausea, vomiting, abdominal pain, they should immediately stop the medication and get in touch with the provider, and they will need further evaluation. Then when using these medication in combination with insulin or other drugs like sulfonylurea, glipizide, glyburide, that can increase the risk for low blood sugar. So usually your provider will decrease the dose of insulin or sulfonylurea when you get started on these medication. Weight loss can be seen from 5 to 10 pounds, depending on how the person is, to how much activity, how much decreased intake the person is doing. Then there is a very rare risk of this called the Fournier's gangrene that can happen in the genital areas, that infection, like redness. It's a serious condition, so it should be immediately treated. Again, these are very rare conditions. Lower limb amputation risk was seen in patients in studies with Involcana, and these were more commonly seen in patients who had prior history of amputation. They have poor circulation in the legs, and they have neuropathy. So just to be aware of these other complications which can make them more prone for amputation of the lower legs. Then the bone fractures, they were also seen with Involcana. Then these medications should be avoided during the pregnancy, especially second trimester, third trimester, because again, we don't know how it will affect the fetal kidneys because it does cross the placenta. And the same thing with the breast milk also. So with the breastfeeding, it should be avoided. Next slide. So these medications can be used in patients with kidney problems. Again, the dose has to be changed based on their GFR. That's a way to check where the stage of the kidney damage is. All of these drugs can be used. The lowest, like GFR, if you see with the dapagliflozin, which is Farsiga, they can be used as low as like 25, and even the other recently even up to 20. So they can be used because they have been shown to be helpful to prevent further progression of kidney damage, other than managing the diabetes. Next slide. So these are different drugs. I mean, they have different indications. So as you see over here, first one, Involcana, all of them, they have been approved for treatment of patients with type 2 diabetes. The Involcana has been approved to reduce the cardiovascular mortality and risk of major cardiovascular events in adults with type 2 diabetes and established cardiovascular disease. Then to reduce the risk of end-stage kidney disease, doubling of the serum creatinine, cardiovascular deaths, and hospitalization for heart failure in adults with type 2 diabetes and diabetic nephropathy with a albumin secretion of more than 300 milligrams per day. So basically, cardioprotective and also renal protective. So it affects a lot of other organs other than just by improving blood sugars. The Jardians, the second drug, empagliflozin, this is the current FDA indication to improve the glycemic control in patients with type 2 diabetes, then to reduce the risk of cardiovascular death in adults with type 2 diabetes and established cardiovascular disease, and then to treat patients with heart failure with a reduced ejection fraction, regardless of whether they have diabetes or not. So this is important to know. We'll be using these drugs more and more, even in individuals without any history of diabetes, because of their cardioprotective effect on the heart. So this is for heart failure patients. Next slide. The dapagliflozin, that is the Farsiga, approved for the glycemic control in patients with type 2 diabetes. Then it has been shown to reduce the reduction of heart failure hospitalization in adults with type 2 diabetes and established cardiovascular disease or multiple cardiovascular risk factors. Then to treatment of heart failure with reduced ejection fraction to reduce the risk of cardiovascular death and hospitalization for heart failure. Then again, this drug also has been approved to treat chronic kidney disease, to reduce the risk of end-stage kidney disease, doubling of serum creatinine, cardiovascular death, and hospitalization for heart failures who are at risk for disease progression. This drug is not recommended in adults with polycystic kidney disease, that's a different form of kidney problems, or in patients who are requiring or with recent history of immunosuppressive therapy for treatment of kidney disease. And the last drug, Steglatro, for the time being, it's just indicated to improve glycemic control in adults with type 2 diabetes. It still does not have the other indications, studies are ongoing, but at least these drugs have been approved for treatment of diabetes along with its cardiac protection and the renal protection. So that's why you see a lot of indications now coming from FDA to be used in different individuals with heart failure and without any history of diabetes. So next slide, I think this was the, and this is the last slide. So this is the algorithm given by the American Diabetes Association. So if you can focus on just on your left-hand side. So first line therapy still metformin when somebody is diagnosed, along with diet, exercise. And then the pathway goes to if the person has underlying heart disease or stroke or cardiovascular disease or chronic kidney disease, then we should go this pathway. So if they have underlying heart problems, heart attacks in the past, other peripheral vascular disease, then probably the GLP-1 receptor agonist, they should be used, which have been shown to with proven cardiovascular benefits. Or we can also use SGLT2 inhibitors. As I explained, they also has been indicated for this purpose. If the second thing is if the heart failure or chronic kidney disease predominates in patients with diabetes, then probably the first choice will be SGLT2 inhibitors. So then we have to use those class of medications by mouth, and then the GLP-1 receptor agonist can be added on top to improve the cardiovascular mortality and decrease their hemoglobin A1C. So for the first time, the ADA has separated that at first when you evaluate the patient, look into their underlying heart disease, kidney disease, heart failure, and then pick the drugs which have been shown to be very beneficial as compared to like treat everyone the same. So I will stop over here and we will later on next time carry on with the rest of the medications and then we'll go to the insulin. Thank you very much.
Thank you, Dr. Handel. I do have a question.
Yes.
What do you do with your, I was going to say students, sorry, it's the university today, patients who do not want to take a shot?
Then you have the Rybelsus. That's the only one oral GLP-1 receptor agonist available. So,
we hope that's covered. And then
yeah, that's always a problem. So again, as you know, with all these new medication, they're expensive medication. So ultimately, slowly, patients, it's an education. They slowly teach them, okay, medications are not working. So it's not your fault. Your body is not making sufficient insulin. So there's a choice that you can either continue the deterioration in your heart problems, kidneys problems, all the complications, or with better control of diabetes, if you have to take insulin or these GLP-1 receptor agonists, you can delay the progression of these complications. So some people will hear you, they will follow your direction. There are some people it's very difficult. They will, after unfortunately a lot of damage has happened, then one day they will say, okay, let's go on insulin or any injectable therapy.
And I do, I have a lot of people who are very interested, although the ones that are refusing injection, a lot of questions about the GLP-1. I think there's a lot of commercials, and then there's a lot of, because of the weight loss with them.
GLP-1 receptor, one of them is now also approved for weight loss as well. The semaglutide at a higher dose is now is being now promoted for FDA indication for weight loss.
I probably get questions on it every day with people asking. So you have to ask the doctor. I don't know. And it's new. So I don't know if your insurance is going to pay for it.
Yeah, at this time, the company is helping with getting people started, but ultimately this boils down to the insurance coverage.
Yeah, it's going to cover it. So, and that's, and one of the things I like too, that I tell, it doesn't seem to have, we don't worry about low blood sugar and things like that, since the worst side effects just seem to be more GI.
Right. Yeah, I mean, again, it depends on which other combination drugs they are using, but ultimately, most of the time, if patients can tolerate metformin, one of the GLP-1 receptor agonist, and then the SGLT2 inhibitors, these are the three top combinations that has no weight loss, no weight gain, no risk for low blood sugar, so and beneficial for heart as well as kidneys.
And I don't know about you, but I do feel like I see some weight loss also with SGL2. And I don't know if it's because you're drinking so much water, if that helps.
Yeah, to some extent. I mean, again, it's a lot of glucose is being now lost in the urine too, so there are extra calories being lost. So usually 5 to 10 pounds or more, depending on how active the person is.
Sometimes I think it's inspiring for them, so then they eat better because they're making progress.
Well, that's why the emphasis is all with type 2 diabetes is to use medication, which helps to promote weight loss. Because insulin is good, sulfonylurea works to some extent, but again, these all causes weight gain and more risk for hypoglycemia. And when people are more often hypoglycemic, they eat more.
Yes. And I think eating more to avoid that how they feel so terrible when they're low. So keep eating to prevent that, and then over treating it.
Yeah. So with these medication, once you've taken it once a weekly injection of the pills, at least that fear of low blood sugar is not there.
That's true. And I do see better eating. I have a lot of patients who notice they don't feel well if they're eating things like hamburgers and French fries, foods that are very slow to digest anyway with the fat. And then they're waking up in the middle of the night with upset stomachs. So we say, well, let's see what happens when you stop eating that. And they feel better and they lose weight. So it's good. Donna, do you have any questions for Dr. Hundle?
I do have one. So I know you were talking a lot about the kidney function and some other side effects of some of the medication. So I know one of the things that we see or sometimes don't see is patients getting their lab work done. So is there a recommendation for how often they should have some of the lab work done to check their levels?
There's no like real recommendation that you should check more often. You have to just use on an individual basis. There's some people who are on a lot of other blood pressure medication, on water pills. These are called diuretics. So those individuals, because these medications also as GLp2 inhibitors can make them pee more. So they may be at risk for more water loss and worsening of the renal functions. So those individuals usually may say, okay, after starting the medication, maybe let's check you 1 month labs, kidney function test in a month. Other routine patients, I mean, renal function, they're not that low. Yeah, you just will do routine labs in 2 to 3 months. But usually the education is the important key, that you tell the person to be well hydrated. And if they watch their blood pressure, if somebody is feeling more dizzy, blood pressure on the low side, then important to decrease the dose of the blood pressure medication, because if you don't do it, ultimately then those people can get some worsening of the renal function because of the decreased blood supply to the kidneys because of low blood pressure. Again, there is no like set level after every person needs to have labs checked every monthly basis. It's not the case. So it's on an individual basis, which provider will explain.
Just being aware of some of the other things, it sounds like.
Just in general, I mean, it's not like you have to drink gallons of water. Just use your common sense and keep well hydrated. Which in general, anybody with diabetes or even without diabetes, we need to drink more water.
Absolutely, got mine here.
I have mine here too.
It's terrible. Have a cup of tea, but I did have a lot of water earlier.
A lot of water. It's full of water.
That's right, exactly. It's the main ingredients.
All right, Amy, are we ready to go back? Let's see if I get back. Can you see my screen now, guys?
Yes.
Okay.
And I'm going to speak pretty briefly tonight. I'm going to see if I should be able to advance, right? Oh, and you advanced for me. Thank you.
Is that where
yeah,
is that
so
where we want to be?
That's where we want to be. So I'm going to speak briefly. So Dr. Hundle spoke to us about medication. As he said, he'll be back in November to finish up the medication. So this month and that month, I'm going to pick a food or a type of food and just focus briefly on why we recommend this type of food. So tonight we're going to talk about squash, since even though it was like 84 degrees outside, fall is coming. So I know I'm ready. I'm hoping it'll be cooler. So why squash? So a lot of times people think when they have diabetes, they can't have any carbs. And if you've been watching any of these webinars, you know that's not true. We want you to eat carbohydrates, but we want you to eat good carbohydrates, so plants. Squash is a really, really good one because it has a fair amount of fiber. It's 6 grams of fiber in a cup. It's only 18 grams of carbohydrates. So for example, and for comparison, a cup of sweet potato, which is another really healthy carbohydrate, it's got a lot of vitamins in it. It's got fiber in it, but that's 41 grams. A cup of pasta, a cup of rice is about between 38 to 42 grams, depending on the type of pasta, type of rice. So squash is definitely lower. The reason why it's lower in carbohydrate is because it has more water in it, but it is starchier than something like onions or carrots or things like that. And it's really a nutrition powerhouse. So a lot of times, if you can think about it being a little chillier outside, that we want to have something that is warm and something that's comforting in the fall and in the winter. Sometimes something sweet, and some of these types of squashes can be sweet, and they're really high in a lot of nutrients. So the carotenoids, which are really good for so many different parts of your body, your heart, your eyes. So beta carotene, lutein, zeaxanthin, which are both very important for eyes and brain health. Vitamin B6, vitamin C, potassium, magnesium, and fiber. So those are just some of the things that are in it. So if you could go to the next slide, please. Thanks. So what is winter squash? So a lot of times when I talk about non-starchy vegetables versus starchy vegetables, summer squash is a non-starchy vegetable. So that's zucchini, that's yellow squash. Remember, when you're eating, half of your plate should be non-starchy vegetables. And that's all vegetables except for corn, peas, and winter squash, which is what we're talking about today. So winter squash is that hard squash. And it's called winter squash, but it's actually harvested now, this time of year. And I get an email from a farm in Newark, and they were talking about they're actually harvesting pumpkins now, because not that everybody wants a pumpkin in September, because it won't be good by Halloween, but because of the weather, they're ready to go. So a lot of squashes are out. And if you've been in the store, you've seen different types. So some of the most common ones around here: pumpkin, butternut squash, acorn squash, spaghetti squash, Hubbard squash, delicata squash, patty pan squash, and there's a lot more. So those are just some kinds. So how do you know the difference? It has that hard shell. Some of the squashes are very thin skin, but most of them, you're going to scoop it out. So we could have the next slide, please. So why should you eat it? Because again, this is going to give you this nice carb that you're going to have with a meal, but it's fiber and it's not really high. And if you're really hungry, sometimes that 1 cup of rice or pasta, it's not going to be enough. This is something that you can eat a bigger portion of. And you're having it with your protein, you're having it with your non-starchy vegetable. You're not going to have a spike of carbohydrate or a spike of blood sugar from eating a carbohydrate like this. It's not, because 2 cups is still going to be less than a cup of pasta. And a cup of pasta usually doesn't seem like a lot when you're hungry. So they're very easy to cook. You can cook it in a variety of ways. And you can make them sweet and you can make them savory. So the next slide, we'll talk about what to do with them and how to cook. If you could move on, please. Thank you. All right, so how to cook it. You want to rinse the skin before cooking, just because it's grown in a field, so you don't know what's on it. And then you can either cook it whole, which you need to pierce because it will explode like a potato if you don't. You can slice it in half, or you can actually slice it and cut it and cook it in pieces. Personally, to me, I find that whole hard squash is very difficult to cut in half. It's like carving a pumpkin, where imagine carving that big thick skinned pumpkin in half. So typically what I will do to get it started is I will take a big knife and usually sort of poke a couple holes in it, and I pop it in the microwave. And I'll cook it in, depending on the size, cook it for a couple minutes and then flip it over. And then when it feels soft, you can cook it all the way. You're basically steaming it in the microwave, or then slice it and roast it if I'm going to stuff it. Boiling it, if you boil, you are going to lose more nutrients. You're still going to have the fiber, but you're going to lose some vitamins, like vitamin C is going to be destroyed at a super high heat anyway, so you're going to lose some of it. Or you can really just microwave. So lots of different ways to do it. You want to think about, what do you want to do? One of the ones I do is spaghetti squash typically. So I'll cook it all the way in the microwave, take it out, cut it open, give it a few minutes so I don't scald myself with steam. I scoop out the seeds and then take a fork and scoop it out, and it's like spaghetti. So that's a very simple one, but there's a lot of other good recipes that you can use where you stuff and things like that. We could have the next slide, please. Thank you. So these are some of the different ways to cook it. So doing something very simple like mashed squash instead of mashed potatoes is to remove the skin and seeds. So that's something I just spoke about doing, but I didn't explain exactly what. If you've never eaten squash before, when you cut it open, there's pulp and there's seeds in the middle. So you can't, well, You're not supposed to eat them. You can roast the seeds, but those you want to remove. So if you've ever carved a pumpkin, again, you have all that pulp in the middle that you have to scoop out, and then the seeds. So any type of squash you do, you want to scoop that middle part out, and then you're going to eat the flesh that's in between the seeds and the skin. So once you have it cooked, you can take out the skin and the seeds and then just put it into a mixer with a little bit of a healthy oil like olive oil, or depending what flavor you want, whether it's peanut oil, canola oil, salt, pepper, any seasoning that you like to have, and mash it. So you have mashed squash instead of mashed potatoes. Again, much lower in carbohydrate. Roasted, most people typically cut them in half. So you have 2 halves open and put it on a baking sheet. It's pretty common to stuff squash. So some people will do this one with something sweeter. So they might do dried cranberries with nuts. You want to be careful with dried cranberries because you can really load up your carb content with them. They're usually sweetened. So, because cranberries are not very sweet. So you want to look for a lower sugar one, or just really use a very small sprinkling. I recommend chopping them so you can spread them out more. Put in something like pecans, and then a whole grain like bulgur or quinoa or farro. So something with a little bit more fiber, that would be more starch. So you want to pay attention to how much you're adding, and then you can roast that. So typically what's recommended is you cook it part way and then you stuff it, you cook it the rest of the way. Squash patties. So I know a lot of people in the summer, I know Donna is a big zucchini fan. So she probably makes zucchini fritters and zucchini pancakes and those things. You can also do these with winter squash. So with all different types of squash, you can mash and you can form a patty, and then take a healthy oil, something like olive oil, and at a low heat. You can pan fry, so not really fry because we're not on a deep fry, but cook it like that. And then spaghetti squash, I talked about, one of the easiest ways to do. When I first introduced people with spaghetti squash, and I had a hard time with it because it doesn't taste like spaghetti, it tastes like squash, but it's very mild. It's certainly, if you haven't had it, it's not like butternut squash or Hubbard squash. It's a little bit easier. So what I will typically do is in a pan, while I've got that going in the microwave, I have garlic and onion and any vegetables I might have. So whether it's tomato or eggplant. And then I put my squash in there. So my squash is now flavored with the garlic and the onion and the tomato. And then you eat it like you would spaghetti for considerably less calories. So a cup of spaghetti squash is 41 calories. A cup of spaghetti is 200 calories. And again, much lower in carbohydrate. So it's a good thing to add in to your fall and winter menu. And they're pretty easy. And if you buy one and you don't eat it right away, it'll last for probably at least a week if you keep it in a cool place. Could I have the last slide? I think it's the last one, please. Thank you. So again, squash is an excellent choice. Hopefully I've sold some of you on it. And then root vegetables, I'm going to talk in our next food one. I'm going to talk a little bit more about soups and stews and some of those winter foods. But root vegetables are something that you can look at too as a better choice than a refined carbohydrate. So if you're eating something like spaghetti, it's made from flour and it's milled, and it's not an intact grain. So it's going to digest faster and raise blood sugar faster. But if you're eating a root vegetable, it's going to be digested a little bit slowly. There's generally more water in it, and there's a little bit more carbohydrate. White potatoes are higher. So I do recommend that you eat the baby red or purple, the really small ones, because you get a lot more skin. Which is more fiber. And instead of mashed potatoes, think about mashed rutabaga. If you haven't had a rutabaga, it's a very mild root vegetable. It's lower in carbohydrate, it's lower in calories, as is celery root, as is parsnip. So these are things that are sold in every grocery store. If you think, well, I don't know what that looks like, I don't know what it is, you can read the tags, you can ask. They're not expensive. So it's something that you're not going to eat a huge amount of. A rutabaga is pretty big. So you only need to buy a couple, and it's definitely considerably cheaper, especially if you're eating a lot of things like pasta and rice. This is going to save you money, have more nutrition, and help your blood sugar. And that is the end of my squash recommendations.
All right. Do we have any other questions or comments? I'm going to stop sharing here. So do either of you have any other questions about the medications, the food, anything else that relates to tonight?
Right. Dr. Hundle, insulin is part of your last one, right? Is that what you haven't covered yet in November?
Just there's some like oral medication which we rarely use it. So mostly it will be insulin.
Okay. So that will be I don't have the date. That will be the second week in November. Which I can look right now. So that's the 10th, November 10th. We'll talk about that. I'll be talking more about food, but I don't have any other questions now, unless you do, Donna.
Do we have, so just to wrap it up for this evening, so we talked about Dr. Hundle coming back in November, but do you have our October?
Yes. So at the end of this month, on September 22nd, we have our next support group meeting, and we're going to be talking about meal ideas. So a little bit what we talked about tonight. So some different things that you might not think about, and ideally we can get support ideas from each other about some ways to get more nutrition in your diet. And then our next webinar is October 13th, and that is me as our speaker. We're going to be talking about mindful eating. So there may be some mindful eating experiments, Donna, so get ready.
I have one question about this sweet potatoes and the just regular white potatoes. So between the two in terms of calories and carbs.
So
Some light.
sweet potatoes have more fiber. So even though the carbohydrate's pretty similar, there's more fiber in the sweet potato. So it's better for you. It also is a little bit more nutrition. The issue that I see with white potato, I mean, it does have a fair amount of nutrition. A lot of people don't eat the skin, so they're not getting as much fiber. And there's a lot of unhealthy ways to eat a white potato.
A lot of butter, salt, and
yeah, so a lot of butter, a lot of salt, a lot of frying, a lot of French fries, cheese. So that it goes back to my recommendation with the white potato to eat the baby potatoes, because then no one's peeling those little potatoes. They're always eating the skin, and you get a lot more fiber. When I talk about sweet potatoes, one of the things I will often mention is sweet potato fries are not healthy. They're still French fries. A lot of people will get those because they think it's a healthy option. Yeah, but that's a good question. Thank you. As a lot of people don't really like sweet potatoes, I find. So I push them into.
I think if you have to eat maybe those type of fried things, maybe onion, those type of rings.
Yeah.
Then the potatoes, at least less carbs coming in. But again, outside it's still that fried food and fried and all the oils.
Yeah, there's a lot of fried. People really like that fried food taste. It's really popular.
I usually tell some of my patients that these are all like these the French fries and nothing. So usually, okay, maybe try in between these onion rings. So at least less carbs will go in.
Less carbs, yeah. But sometimes some of the restaurants, the fried onion, the breading is so thick.
Yeah, the bread. I mean, again, it depends on the restaurant. But sometimes the bread is so thick on the outside that
I think that the carbs are they're pretty similar. And a lot of patients now, I don't have one, is an air fryer. So one of the things I will talk to them about is cutting a potato and cooking it in the air fryer as a better choice, and sometimes people think if they buy the French fries in the bag and put them in the air fryer that it's healthier instead of frying them, but they're fried in the factory. So that's why they taste good. Yeah.
Just again, everything in moderation. The portion is
really comes down to portion. And I know at one of our webinars we talked about plate size and all of that.
If you like French fries, you can have 2 or 3 pieces only, rather than people full plate of French fries.
Yes.
And still enjoy your life by just having the right portion size.
Eat them slowly and give them away, the rest of them.
All right. And so I think you were talking about, so mindful eating, and then October. Do we have our October support group?
Well, our October support group is.
You don't have it, that's okay.
I know I didn't write down the topic for our October support group. I'm looking to see, and I don't have it here. I apologize. I'll have to bring it up at the end of the month.
You'll have to join us in September to find out what October is.
Yes.
Or actually, we'll talk to you about it in our October webinar as well. So we want to thank everyone. And I know Amy's mentioned it a few times. So if you are interested in seeing some of our other webinars, we have, as she said, a host of topics, several with Dr. Hundle walking us through medications and some other anatomy and physiology around diabetes. We also have had a lot of other specialists, cardiologists, the nephrologist, an optometrist, podiatrist. So we have a lot of those out there. We have a YouTube channel under United Medical LLC. There's a whole library of webinars going back to when we began. And we used to do them twice per month. So we do have quite the library. You can also find them through our website at umusa.net. And if you go under For Patients, we have our wellness programs there. And under the diabetes program, you'll see not only do we have the webinars, but Amy's also done a host of quick tips. So she's talked about mindful eating and food prep and checking your blood sugar, reading labels, fiber. So she's done a lot of those. They're only 3 to 5 minutes. Again, the quick tips. We also have a lot of handouts out there. So we do ask you to go out there and look at some of the resources that we have. And we'd like to thank you for joining us tonight and enjoy the rest of your Wednesday.
Thank you.
All right. Thank you.